Hey, well, good afternoon or morning. I don't know where everybody's joining us from. Give everybody a couple of minutes to get in and log in for today's webinar. If you're here with us on a Friday, you know that on Fridays at noon, NMKF likes to work with our partners and edutain. And so give you a little bit of education and entertain you on some topics that are important to us and our partners. Before I go on, I just want to remind everyone that this upcoming Monday will be our 24th, I believe, annual summit on health disparities, where our moderator will be receiving an award there. But it's called Access 26, and this webinar is sort of like we're the third leg in a relay race, and the fourth leg will be this program at the summit. And in this webinar, we're going to talk about addressing access and affordability policy barriers in critical care. And so we're looking forward to that conversation. That's going to be led by Ashley Szofer. She's from right outside of Chicago, right, Ashley?
I am originally from Orland Park, Illinois,
Orland
Chicago
Park,
suburbs,
Illinois.
yes.
Chicago suburbs, yeah. So she's right from Chicago, just like near Congresswoman Kelly, and near my sister, actually. But we're going to put a little information about the summit in the chat. If you have a chance to come by, if you're in DC and want to stop by, just come check us out. Come check Ashley and Gary and Lisa. And I'm trying to think of anybody else that's going to be. Yeah, that'll be at the webinar. But without further ado, I'm going to turn it over to Ashley, and she's going to lead today's webinar. She's far more knowledgeable in this topic than I. So
Well, thank you, Brandon, for that. And just want to say thanks to everybody for tuning in today. I know it's a Friday afternoon and love to know that people are interested in learning more about access and affordability issues. So just really grateful for everyone for tuning in. And then just as always, thank you so much to the National Minority Quality Forum for creating these spaces and platforms to engage in dialogue between patient advocates, industry leaders, healthcare providers. And so in that vein, today we're going to hear from a unique blend of advocacy leaders just working across research and data, advocacy training, and personal experience to bridge the gaps in education, resources, and opportunity to enact meaningful policy reforms, particularly as it relates to programs like 340B, proposed and current drug pricing policies, and just what are some of the actionable next steps that we can take. So joining us today are Gary Puckrin, who really needs no introduction, the CEO of the National Minority Quality Forum. We have Lisa Berkey, who is the Senior Director of Health Policy at the National Consumers League. Lizzie Whitting, who is the Vice President of Heal Policy Center at Excellence at the Tiger Lily Foundation, and Garina Ross, who is a metastatic breast cancer thriver and Tiger Lily Angel. So just to kick us off with this conversation, Gary, would you mind setting some contextualization and about the 340B program, what its original intent is, and then where you're just finding overlap between a lack of program transparency and barriers to care, and particularly for oncology patients?
Great. Well, thank you so much, Ashley, and welcome to the other panelists and to the audience. I'm going to ask Ashley to put up a slide. So my curse is I'm a historian, and I always go to first cause and always trying to understand exactly where we are and how do we get here in the context of healthcare. And oftentimes everyone says that our healthcare system is very complex. But it actually has some very simple underlying components to it that is really important to understand. This is a slide that was created by Uwe Reinhardt, who was a economist at Princeton University. It was published in the New York Times in 2011. And basically what he was looking at is the flow of funds. And what they say, follow the money. So I wanted to start us off by following the money as we get into 340B and understanding other things that are going on. Probably the most important thing for you to know is that uh, all of the money in the healthcare system comes from American households. Sometimes people lose sight of the fact that it is our money, but it is our money. All of it is our money. And we put in about $4.5 trillion a year into the healthcare system. And if you do a comparison, that's larger than the whole GDP of France, and it's larger than the GDP of Germany. So the German GDP is $3.2 trillion, and ours is $4.5 trillion. So when you start to get into conversations about most favorite nations and everything like that, you're comparing apples to oranges in terms of size of what we invest in healthcare. The thing I want to point out to you the most is a lot of what's going on in healthcare is federal taxes. And what's important about that is if you're working in the United States, you pay taxes, and those taxes go into programs like Medicare, VA, Medicaid, et cetera. That's what's important. And the important part about that is that in effect, you are captive in the system. You can't opt out of the Medicare program. And so what government is doing is taking all of those dollars and it becomes the payer in the system. The federal government is the largest indemnifier of American lives in the country. It's larger than any private commercial plan. And if you do the comparison, what you understand is that it's a monopoly purchaser. It has the power by law to set prices, to set distributions, et cetera. And so when people talk to you about single payer, what they're really talking about is giving government total authority over everything that's going on in our healthcare system, which is unusual. We are a free market economy, but our healthcare system doesn't operate as a free market economy. It operates more like a command economy because of the role of government. So government comes in, and one of the habits that government has is that, guess what? It likes to pay under the cost of care. This is what creates, if you listen to doctors and hospitals and device manufacturers and innovative companies in early detection or pharmaceuticals, they're always talking about the fact that what government wants to reimburse is below the cost of care. So when you think about MFN, IRA, coverage with evidence development, CBO scoring, it's all the same thing. It's government coming in and saying, guess what, guys, I want to pay you less than what it actually costs to deliver the care. And so the minute the government does that, it creates all kinds of distortions in the marketplace. It creates all kinds of problems because what it means is that the provider either has to find some other way to cover that cost. If you look at hospitals, they ramp up the cost to commercial insurance, or it affects the quality, or it outright leave the market, or it denies access to certain individuals. And so those market distortions get built in. What happened though with hospitals is that government comes in and it's paying below the cost of care, and it's got a problem with the safety net hospitals. How do we support them? And it didn't want to quote unquote pay them, and so it came up with the 340B program. That's how the 340B program gets put into place, because what government was saying is, guess what? I will allow you by law, because it's a sovereign entity, so it can do what it wants to in the marketplace, which a commercial insurer could not do. It comes into the marketplace and it says, look, I'm going to allow you to purchase prescription drugs at a discounted rate, right? So I'm going to tell all the pharmaceutical companies that you got to sell your product at a discount to these covered entities that we identified. And so, and then what I'm going to do is I'm going to allow you to sell that at the market rate. And so the difference between what you bought it at the discounted rate and what you sold it at is the benefit that you now have. And by the way, we're not going to audit that. We're not going to say that you necessarily have to spend it in this community or do it anyway. It's just money, right? But we're doing it because we believe that you'll do the right thing and you'll take care of the safety net communities, et cetera. So that's how the 340B program got started. And guess what? Everybody said, oh my gosh. and so it started to expand. And so right now, the 340B program is doing about $70 billion a year, right? And it's not audited money. It's a program that the government set up. And, we can go back and forth about how well it's audited. You have some states that have started to come in and try to do some auditing around it. But the program works so well that some of the states decided, well, we'd like to do some of that. And so they start launching PDAP programs in which they set the price of medicines and then distribute it back out to hospitals. And obviously, the hospitals are concerned about any attempt to move the 340B money. They argue that it covers the cost of what they provide to safety net communities. And, we can go back and forth about whether that happens or not. And what you should understand is that the individual who receives the medication, so the hospital or the covered entity submits the claim, but that claim doesn't necessarily have to be tied to someone who is underserved or can't afford the medicine, or anything like that. It could be anybody in the system, as long as they are associated with the covered entity, and there's a whole back and forth about how all of that gets set up. And so what I'm explaining to you is what also happens on the back end. It's not that these households get the benefit of that discount here. No, they don't. They end up with a higher bill because it moves over to the commercial payers, and so the commercial insurance pays money. They get hit with medical debt. They get hit with all kinds of problems as a result. But what's important about all of this is that I'm just talking to you about the money, right? I'm not talking to you about the quality of care, the quantity of care, patient risk mitigation. None of that's in the 340B program. You're not going to find one metric in the 340B program that said life expectancy went up, people stayed out of the hospital, we're benchmarking it against anything clinical. That's not what it is. That's not what it's designed to do. And so that is the 340B program. I could take you through all of the other IRA, MFN, coverage with evidence determination, CBO scoring. It's all the same thing, right? At the end of the day, it's just the same thing under different government programs. And sometimes the same drug is hit with the same set of government financial schemes in effect. And so the complexity in all of this isn't about the money flow. It's about how government decides to present it and how it wants to move the decks on the ship, the chairs on the ship. And so I thought it was important that we start understanding exactly what's going on here, because the American public are absolutely clueless. They have no idea, because when you say 340B, it makes their hair hurt. I don't even know what the heck that is. But that's the way the government works. It comes up with all these fancy names and complicated doodads and whatever. But at the end of the day, it's not doing what healthcare is designed to do, which is to improve the quality of life. And that is probably the most important thing you should walk away with. Thank you.
Thank you so much, Gary. So helpful and just really great helping us ground this conversation, and appreciate that perspective. And then so the National Consumers League just recently released an issue brief examining oncology medical debt practices among 340B and non-340B hospitals. So Lisa, I'm just going to hand it over to you to talk about what that issue brief found, and then what.
Ashley, do you want to pull up the slides?
Sure.
Thank you. So I'm Lisa Berkhew, National Consumers League, and I'm going to dive into some of the things that Gary talked about, principally around 340B and that medical debt issue, and really whether 340B is helping patients as intended, which I think after you're going to see at the end of this presentation, what we're concerned about is that it's not. So can we go to the next slide, please? Okay, so just in case you haven't heard of NCL, we are the nation's oldest consumer advocacy organization. we don't just work on healthcare, we work on a variety of issues, including food, nutrition, and obesity. We do a lot on workers' rights. That's really where we came from, and a lot on child labor, particularly within that area. And then also we have a department that works on fraud and privacy issues. And so as part of the healthcare work, really our North Star is championing access to more affordable and high quality healthcare. And so that's where all of our work and all of our concerns about 340B really come in. Next slide. Okay. So as Gary kind of alluded to, we really support the original intent of 340B. This whole program was created to help hospitals stretch limited federal resources so that they could help low income and uninsured patients access their care and afford their medications. But what we're finding, and I think what the research is really showing, is that these savings aren't being passed on to patients. Hospitals, and particularly large hospital systems, are keeping this money. They're using it to profit, as well as some of these large pharmacies that we know about and large PBMs that are also under the same ownership of pharmacies. They're also profiting up the program while patients are really suffering and really having tight financial strains at the end of the day. And so at NCL, we try to advocate for patient-centered reforms so that this program actually is helping patients as it was intended to do when it was created. Next slide, please. So just turning to the medical debt issue, this is a uniquely American problem. It has impacted a majority of American adults. So we did some research on this and found that 25% of US adults currently have medical debt and 29% had it previously. And it's something that disproportionately impacts minorities. So depending on which study you're looking at, but generally speaking, Black and Hispanic families are much more likely than white families to carry medical debt or struggle to pay a medical bill. And when thinking about medical debt, I think it's important to recognize that we're not talking about discretionary spending. This isn't choosing to go buy, a fancy car or going out to purchase your own home. This is something that arises because you have a serious medical issue. You have cancer or a heart attack or a stroke or a car accident or your kid gets sick. So, you're not choosing to be encumbered by this debt. And if you are encumbered by this debt, there are really significant consequences that come from that. So, and these can be financial, it can be medical. So it can damage your credit, which impacts your ability to purchase that house or to purchase that car down the line. It can drain your savings, and it can lead patients to delay follow-up care, which is really concerning when you have a serious condition like cancer that requires regular follow-up to stay healthy. And then the last thing I think I want to mention about medical debt is that this is only a problem we're going to expect to get worse. So the fact that Congress did not extend the enhanced premium tax credits, so everyone's premiums are just skyrocketing right now. The fact that President Trump signed into law HR 1, which is going to result in a lot of people losing access to Medicaid over the next couple of years, everybody's still going to get sick. They're still going to go to the hospital. They're still going to get these medical bills. And they're going to be falling, unfortunately, more into medical debt because they're not going to have the insurance they need to provide sufficient coverage. Next slide, please. Okay, so about a year ago, we did a national poll of 20,000 American adults, and we were looking at the intersection between medical debt and 340B. And so what we found is that medical debt is most commonly incurred during emergency care. Diagnostic tests, we all know how expensive MRIs are when you have to get those, or if you have to get CT scans, doctor's visits, and it was also incurred most commonly during hospitalization. I think a lot of people, when you think about medical debt, you think about the uninsured population. Of course, medical debt, is going to impact the uninsured population, but it also greatly impacts the insured and underinsured population. So we found that 67% reported that their insurance only partially covered the cost of their treatment. And so that's why they went, or at least that contributed to their medical debt. And then as I alluded to earlier, this can have a major financial impact on people. So we found that 68% had to cut back on extras. So thinking about things like travel, 55% had to cut back on necessities. So back to school clothes or food, dinners for your kids. 54% had to skip further medical or dental care, and 37% say it negatively impacted their credit score. Next slide, please. So there was strong support for policies within our survey to tackle medical debt. So some of the ones we floated included requiring providers to offer payment plans, and then prohibiting hospitals or providers from denying care if a patient already has medical debt, which is something that does happen. Along the lines of what Gary said, familiarity with 340B is very low. Less than 10% of people that we surveyed were actually familiar with 340B. But once we provided a neutral definition of what 340B is, they really liked the whole idea behind it, but they didn't like the abuses that we raised. And so as a result, we found that 75% think, or 79% think that reform of 340B needs to be a top priority for lawmakers right now. Next slide. Okay, so now I'm going to dive into that issue brief that Ashley mentioned. And so what we wanted to do here is look at that intersection, again, between 340B, medical debt, and cancer care. And the reason why we looked at cancer care is because oncology drugs make up a really significant proportion of the drugs that are purchased through the 340B program. So the way that we did that is we reviewed data from 2,500 hospitals. And what we found is that 340B hospitals, including a lot of those hospitals that treat large numbers of cancer patients, are much more likely than hospitals that aren't enrolled in the 340B program to permit aggressive medical debt collection practices. So we're talking about things like hospitals filing lawsuits against patients, garnishing their wages, so taking their wages from their paychecks, placing liens on their private homes, and submitting the medical debt to credit reporting agencies. Next slide. So just diving a little bit deeper into the data, this slide shows medical debt collection practices at 340B versus non-340B hospitals. So the blue lines are 340B hospitals. The red lines are hospitals that aren't enrolled in the 340B program. So you'll see, for example, 72% of 340B hospitals may report debt to credit agencies as compared to 61% of non-340B hospitals. Similarly, 75% of 340B hospitals may take legal action against patients as compared to 62% of non-340B hospitals. Next slide. So just diving deeper into different types of legal action that hospitals can take, you can see here, once again, across the board, 340B hospitals are more aggressive in their medical debt collection. So we're talking about things, whether it's placing liens on patients' property, suing patients, or garnishing their wages. Next slide, please. So turning to the cancer care piece of this, among hospitals with a really high volume of cancer patients, legal action policies were, again, more common in 340B hospitals. And so as the cancer burden increased, so if you're looking at this slide on this graph on the right, so as we go from high prevalence, which is the top line, to very high prevalence, which is the bottom line, the medical debt policies at 340B hospitals remained consistent. So they stayed around the same from 75 to 72%, while the medical debt collection policies actually declined at non-340B hospitals. So as the number of patients with cancer actually increased at non-340B hospitals, they became less aggressive in their medical debt collection practices. Next slide. So just thinking, holistically about this, we have this program that's intended to help low-income, uninsured, vulnerable patients. And what we're finding is that patients are going into medical debt. These hospitals are aggressively pursuing them for that medical debt, which is really concerning when you have situations like oncology having settings where that continuity of care is really important. And so we think that federal reform, I think, is really urgently needed right now to address some of these issues. As patients are only going to go more into medical debt, their premiums are skyrocketing. They're going to be losing access to Medicaid. We really need to make sure that this program right now, which is intended to help these patients, actually does, just given everything going on over the next decade. So that's one more slide, I think. The next slide is just some resources. The first is our health website, which contains all of our 340B work. We have got a lot of resources for folks. And then the second and third are the issue brief and survey that I alluded to. Thanks.
Thank you so much, Lisa, for that fantastic overview and for all of the work that you guys are doing and continuing to do to educate people on these issues. We're going to turn it over now to Lizzie to share some of the work that you guys are doing at Tiger Lily and how you're helping train advocates and share resources and create resources. And I'll let you talk more about that work.
Thanks, Ashley, and thanks again to NMQF for having us today. Happy to be here and be talking about this with all of you. It's such an important issue, as Lisa was just sharing, especially for cancer patients. So at Tiger Lily, we are a national women's health and oncology nonprofit, and we focus on advocating for, empowering, educating, and supporting young women before, during, and after cancer. So this is especially important to our community and our advocates. And so that's, is an important issue to us and something that we've been engaging in for quite a while now. For 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 thinking about our community and why 340B matters here, and some of the other issues that Gary was talking about too, with PDABs and MFN and drug pricing policies. As a whole, our patient populations who often face systemic barriers to care and significant financial toxicity, like cancer treatment is not cheap for anyone, no matter what. But a fully functioning and operating as intended, which we all keep talking about, 340B program can really be a lifeline to patients, and that's what it should be. But as we've seen, and thank you, Lisa, for going over a lot of that, the kind of aggressive medical debt collection through some of the larger 340B hospitals and some of the differences and disparities there. That's not always happening. And so that's what we're really committed to, as you guys all have said as well, making sure that the benefits of this program actually go to the patients as intended. Because at the end of the day, when you look at this program was intended to help the most vulnerable patients. And the misuses and abuses that are happening within the program are essentially taking away, or dare I say, stealing those resources meant for those patients away from them and using them for profits and for other things that they were not intended or not supposed to be used for. And so that is in and of itself a huge issue. But the real impact to the actual patient is where we come in and really want to make sure that we're highlighting. So I think we've all touched about this too. Like, so many people don't even know about this program. I always say it's the biggest little known program in the US. I think it's the second largest healthcare outside of Medicare Part D. And nobody has heard of it unless they work in this space or they've been affected by it and have found out somehow. There are no signs when you go into a 340B hospital that they're a 340B hospital, and some of the drugs there they're buying through a discount. When you get your drug at the pharmacy, there's no sticker on it that says this is a 340B drug and was purchased at a discount. None of that's happening. And it's not being talked about widely, and it's really hard to understand too. So, and that kind of feels by design sometimes. So part of the policy and advocacy work that we've been doing is not only educating our community members and patients about this program, that it exists, what its intent is, and what's actually happening now, and how to engage in that advocacy. But on the other side too, we've also been educating policymakers, state officials, federal and state, about this. And more, I'm going to speak to last year because I know those numbers for sure, and I think this year is similarly. But last year in 2025, 28 states introduced different 340B, just contract pharmacy legislation, right, to protect that expansion of the pharmacies that we've talked about in the past. And it's been about similar this year. So while we do advocate for reform at the federal level, we know it's stuff's happening at the state level too, and so we have to engage there as well. And what we found is that a lot of policymakers don't know about the program either or understand what's happening. And there's a lot of almost what feels intentionally misleading education and naming around this. A lot of the state bills that are introduced that we're talking about are called like Protect the 340B program. And in reality, they're just protecting that contract pharmacy expansion piece that is a huge area of abuse and misuse, or charity care at hospital systems, all these different things. So there's been a lot of education there as well around, like, if you don't pass this bill that sounds like it's going to protect the whole program and protect the patients, the program is not going away. it's going to stay as is. And what we're really trying to do is make sure that we're not codifying or giving legal precedent or setting up laws that's going to protect the misuse that's happening of this program. And that's been a little bit difficult over the last year, but is just really important, for all the reasons we've talked about, and just kind of holistically as well, making sure that we're looking at all the different concerns. So the limited patient benefits, of course, are our first concern, making sure that that actually goes to the patients, that they're getting discounts on the drug in some way or getting charity care or support through that, those saved money. And then, we're also concerned about increased cost of care, which you heard both Gary and Lisa talk about too, how that kind of just shifts it throughout the entire network and system of our healthcare system. Um, it's also shifting the program to this focus on profitable patients, right? So these clusters of affluent neighborhoods and larger hospital systems, funneling patients back into those from like the smaller clinics and everything. Um, just all of that. So what we're really looking at, all that say, transparency, accountability, and making sure that there's patient access are our focuses in the kind of reform and advocacy that we're doing right now. And so that's what we're focusing on. So we have a program called our Angel Advocacy Program, which Garine is here today to talk about as well too, and some of the work that she's doing. But we offer this as a free training program to anyone who wants to become a patient advocate. And they go through that, and then they get these advocacy opportunities, and we can help educate about issues like 340B or PDABs or MFN, all these things. And then what we're really trying to do is just arm our community and network with the information, the resources, and an easy way to engage in all of that, to use their voices like Rena's doing today, to share their stories about the impact here and influence legislation and reform and changes in a way that are going to protect patients. And that's really our focus there and what's of the utmost importance to us. So again, protecting access to care, helping ensure that those clinics and hospitals within the 340B program can continue offering affordable medication, or can, but will and do, offer affordable medications and essential services to patients who need them the most and who this program is intended to help, keeping those costs from becoming a barrier. We all know medical debt is like, I think, number one or two reason for bankruptcy in this country. That's a real issue and concern, and something that we have to be addressing as well. No one should be having to decide, like Lisa went through with the survey as well, whether they're going to put food on the table for their family or they're going to get the drugs that they need to keep them alive from their cancer diagnosis. That's not fair, and that should never be happening. And again, just amplifying the patient voice, making sure that those stories are being heard, that those perspectives. So we continue to do that, again, both on the community network side, but also policymaker side, and do that through sharing with our communities, sharing those patient stories, sending letters to legislators, either at the state or the federal level. We try to make that very easy with little templates. You just click a link and can send it based on your address. And talking with legislators, whether that's at virtual calls and meetings, in person in district or at Capitol offices, even on the phone, just calling and leaving a message, all of that makes a huge impact as well. And then just, demanding that patients are getting the benefits from these programs. So I know Green is going to do a much, much better job talking about this, so I'll keep it there. But that's really where Tiger Lily is focused. And we've also been creating some toolkits, which I can put a link in later to share for other patient advocacy groups to use as well, who maybe don't have a policy arm or a team that, or the capacity to engage in this from scratch. So we've provided templates for all those things, the letters, the talking points, one pagers, all the facts and statistics, like how to tailor it to your patient groups and communities. But at the end of the day, for us, it's this access issue and also a health equity issue, because again, these are the most vulnerable patients that are supposed to be benefiting from this program, and that this program was designed to help. And those are the ones that are actually getting those resources taken away from them. So I know we've gone over and everyone's very clear about that, but I'll leave it there and come back after Karina shares if we need.
No, thank you so much, Lizzie. I think everything you just said is so important, especially because people don't know necessarily what what the source of their barrier is. And I think what I'm really excited about, to hand it over to Karina, is when we have a lot of these conversations about policy and about access, we're getting technical, we're talking about the money, and it's easy to kind of forget sometimes that at the root of that are actual human experiences and people that are navigating this in their daily life. So, Garina, thank you so much for joining us and sharing your story. And I'm just going to hand it over to you because you'll do it a lot better than I can. So.
Well, thank you so much, Ashley, for that wonderful introduction. It is such an honor to be here discussing one of my favorite topics here that has led me into becoming an advocate with the Tiger Lily Foundation as a breast cancer thriver. This journey started when I was just 36 years old, being diagnosed with inflammatory breast cancer at the time. It was at a stage 3, 4. So, I had to go through my treatments at that time, medication, no co-pays or anything. Was able to receive my chemotherapy, double mastectomy, and everything. I had a little bit of medical debt due to the fact that I had to continue to go through doctor's appointments and MRIs and CT scans. As Lisa has stated, those things are very expensive. And then I started noticing I was being billed incorrectly. So I started looking at my explanation of benefits, making sure that the days that I were going to the hospital and to my doctor's appointments, that I wasn't being double billed. So I literally kept every single explanation of benefits to help me continue to keep track of what I was being billed for. And it got so bad to the point to where, the bills started going on my credit report, as Lisa stated, that the hospital, has started, you know, um, submitting information to the credit agencies. So my credit had, it was affected. And then, it forced me to go into my 401k and start pulling money out of my 401k, which went into my savings. Um, and then at that point I had to create a GoFundMe, and it was just for a small amount after reaching out to the creditors to negotiate, some type of settlement, because I didn't want to not pay it. And, it was my responsibility because I had to get my treatments. But at the same time, I couldn't stop me getting cancer. I couldn't control that. So, that debt accumulated because of that. So, but I still wanted to be responsible and pay off my debt regardless to what I needed to do. So I started going into my 401k, pulling out money there to continue to pay off my debt, which I finally eventually did, paid off all of my debt, and was able to, improve my credit, get my credit back on track. But a lot of people don't have that, that resource to rely on, their 401k or a savings plan, or, being able to pull themselves out of that that medical debt. So it is very important, that we continue to remember what the 340B program is intended to do. And as an angel advocate, I was pulled into this, and started doing my own research and realized I Lizzie said, or Lisa said, there's no signs at these 340B hospitals or clinics, letting you know, or labels on drugs letting you know that these are 340B drugs, that these hospitals are buying low and selling high, to patients like myself who have great insurance, but due to all the recent changes that have happened in DC, with our new administration, um, my copay has went from $0 to $13,000 just for one round of my drugs that I currently take. There is no way that I can afford $13,000 a month, because I have to take these drugs every single month and still have quality of life, still want to, live and see my grandchildren and continue to raise my daughter. I mean, she's grown, but whatever, she's my baby. But, wanting to be around to, see her continue to, grow and being a mother and, help raise my grandchildren. So, um, learning about the 340B program and realizing that I'm receiving my treatments from a 340B hospital and that the drug that I'm taking is a 340B drug. No one knows that I know about the 340B program. So when I go into these hospitals and I mention that, is this a 340B drug? What did the pharmacy, what did the hospital pay for this drug? And that I'm being charged $18,000 for, and my insurance is only covering four, and it leaves me with with $13,000. I mean, yeah, with of debt to have to pay of a copayment, and I'm like, there's no way that I can. There's no way that I can afford that and still pay my mortgage and pay, have just quality of life and not allowing the medical debt to become stress on me, that it sends me into have increases my health issues, or there's just no way. So I do sympathize with all of the individuals who are going through cancer treatments or any type of treatments, that don't know about the 340B program, and they will refuse treatment simply because they cannot afford it. They don't want to put their family in debt. And it's sad that you people have to choose into, humans, that pay taxes on, that paid taxes, did what they were supposed to do, you know, and still cannot receive the resources that they need to help them at the time that they need it, all because they're still working. I worked my entire treatment plan, so I wasn't eligible for any type of assistance from organizations because you have to be low income. I'm not considered low income either. So I didn't qualify for anything. So it put me in debt. But I am thankful that I was able to pull myself out of that debt. But this time around, I can't. I won't even allow myself to even, go through that, to put myself in debt to where it will affect my credit or anything. So learning about the 340B program, as by becoming a angel through Tiger Lily, has been very rewarding. Not only does this help me with educating myself, but I also take this information to my community. I also take this information to other cancer patients. I have people, my neighbors, just reach out to me and was like, "Hey, my friend was just diagnosed with cancer. Like, do you have any resources? Do you know any resources?" And I am a researcher, so that's what I do. I love to research. So I just go online and just, and I reach out to different people to see what type of resources are available to those people, because I never want someone to feel that they have to choose life over their treatment plan, or choose debt over life. So everything, your life is so important, and I try to do my best to continue to be a light to other people, whether it's providing them resources, whether it's sharing my story. And being a part of this journey has been very rewarding. Lisa, thank you. I kept writing down notes as you were speaking, about the facts, about the percentage of hospitals who receive, who are 340B hospitals, and none of their patients know anything about this program. And, meeting with my state legislators and educating them about, how this program is affecting people here in the state of Michigan. I'm honored to be a part of this and to sit with all these amazing people and hear all this great resources and information and statistics and everything. This is a topic that is very dear to my heart, and I continue to want to be a part of it and educate as many people as I possibly can as I continue to thrive and fight through this cancer journey, and be an angel advocate for those that need it.
Thank you so much for sharing your story, Garina. And I think what you're speaking to is just exactly why this work is so important. I think for a long time, when people don't understand, a program like this, they assume this is just a problem between hospitals and providers, and that has nothing to do with me. And the more that we can educate people about how this does impact them, but then also what you can do about it. So thank you so much for being an angel and for doing all of this work. And very timely right now, we have a question that says, how can we receive more information on becoming an advocate? So Lizzie, it'd be great if you could talk more just about how you can bring people into the program, how you help people understand if they've been impacted by this work, that they might be a good angel advocate. So if you could share some more information about that, that would be awesome.
Absolutely, yeah. If you're interested in becoming an advocate through Tiger Lily, we'd love to have you. TigerLilyFoundation.org is our website. I'll put a direct link in here. There's just a little form you fill out, and then we invite you to the next training cohort and get you on. We have weekly opportunity emails where we send advocacy opportunities, and we include a lot of our 340B. There's always a lot going on. So we'd love to have you and get you information and get you equipped and empowered to step out and start doing that. We also, if you're not interested in the training and just want to get involved, that's okay too. I'll put my email in the chat as well, but or I can send it out. But it's just my first name, Lizzie at TigerLilyFoundation.org, and we'll get you plugged in. We have a lot of opportunities because there's a lot going on to do this, to just get educated about it. But to Karina's point, kind of what we start with people is like, the first step for us is really just speak up. And it's as easy as asking those questions when you go to your clinic, your hospital, your pharmacy. Just ask them if they are a 340B entity. And you might not get an answer right away, but the more patients and community members that are asking and speaking up and making it known that they know about this and they want to know more about it and how it's affecting them, is going to make impacts. We've had angel advocates come back and tell us that they asked, didn't get an answer. It got pushed to the next person, an administrator. They got to get in front of them and ask them, like, why aren't I getting any discounts? Why was I declined charity care when I'm low income and you're a 340B hospital? Why am I in medical debt when you're getting discounts on my drugs that I'm getting for my cancer diagnosis? And so there's a lot of great resources too to look up the lists of 340B hospitals and clinics in your states. We can drop a couple in there too, but I know there's a few I like, but there's several out there. So happy to provide more of that information and get anybody hooked up who is interested.
Thank you so much. And yeah, so we are open for questions now. There's a Q&A option that you can ask through there and we can answer live. Those questions will go just directly to us. So if you have one that you just want us to follow up with offline, you can also share that. But in the chat right now, we have a question for you, Dr. Puckrin, which is, did the ACA include any measures to improve 340B? And is the American Hospital Association taking any steps to improve the situation?
Thank you for the question. I'm going to ask Ashley if she'll pull up that original slide for half a second, because there's a point to be made here. One of the things that health insurance does, and it's supposed to do, is the individual consumer cannot come into the healthcare marketplace in their own right and buy healthcare in the same way that you buy a car, you buy a TV, etc. So health insurance is supposed to capture the risk that you have, and it's supposed to provide the support that you need in the moment you need it. So collectively, we all throw $4.5 trillion into the kitty. And what the intent is that when you need the care, that your health insurance pays for it. So what has happened here with these middle guys, because these are the guys who collect the money, they set measures in place that co-insurance, co-pay, all of those things that mitigate that risk that we're supposed to be paying in for. And so it's really important for patient advocates to understand that part of their advocacy needs to make sure that when we're looking at copay and co-insurance, that particularly when it becomes destructive to personal households, et cetera, that's not how the system is supposed to work. And what's happening is these folks in the middle are taking our money in and then deciding how it ought to be distributed. And that's an important conversation to have. Now, on the 340B program, it is technically not designed to provide patient assistance. I want to be real clear about that. I'm not saying that it shouldn't do that. I'm just saying how when Congress created it, um, it was intended to provide support to hospitals directly so that they could provide care as they defined it to the communities. And what you end up seeing is that in many instances, the charity care or the care that they provide community is far less than what they're taking in. Now, there are situations like the HIV clinics, for example, and some of the FQHCs um, uh, clearly use the resources in that way. So I don't want to throw everybody into the same kettle. But the point is that from a system standpoint, and just talking systems now, the program is really not designed to do that. And that's part of what we would say needs to be fixed. And also the transparency. So it is not surprising when you go to a 340B hospital or clinic and you say, so what's going on with the 340B program? They're going to say, well, I don't know because nobody audits them. There's no record. There's nothing there by which they can actually give you an answer to that question or want to give you an answer to that question. And certainly how it impacts the individual in terms of access to care. Because you can find affluent people who are getting the benefit of the 340B program because there's no design in the 340B program that qualifies who is eligible for those medications that are being sold. And so that's some of the structural problems with 340B. As to the ACA, so what the ACDA did was expand the 340B program and came up with new definitions of what a covered entity would be in medications. So the 374% growth in the 340B program is often pointed to ACA, that ACA expanded the program from the original program that was set up in the 1990s. And so I want to be careful here with the American Hospital Association. I mean, they're advocating for their members, and these are dollars that they fight for. Particularly when you look at the data and you see that many hospitals, as it relates to the Medicare and even Medicaid program, are providing care that's less than the cost of care. So back of the envelope, somewhere around 80 to 90% of the cost is being covered, but you could have as much as 20% of the cost of care is not being reimbursed by the government. And that's that distortion that I'm talking to you about, that because the government is not paying the full load for care, it means that the hospital or the doctor or whoever has to go back out into the marketplace and figure out, so where do I get the rest of that money? And somehow the 340B or the commercial plans is what's happening. And then finally, the patient voice is really incredible in this story. The patient voice is the change agent in the system that helps the system, whether they like it or not, understand how the program is actually helping or hurting. And for legislators, it is their constituents because they're the ones who wrote all this stuff up. It's basically their design. And so it's important to go back to them and say, excuse me, I now have a debt of $14,000 a month, which is an incredible number. I just want to be really clear about that. That's an insane number to put on any American household, particularly if you look at the Medicare program. The average household income is $25,000 a year. What are you going to do with a $14,000 a year copay? So, the system is in dire need of repair. And I think, as Lisa said, some of the direction that Congress is going in is the opposite direction, eliminating premium support, undermining the Medicaid programs. So there's a lot of work that has to be done here.
Absolutely. Thank you for that. And I think one of the things that we always keep reiterating through this is that we do want the program to operate as initially intended. And so all of these measures and all of this is not about getting rid of the program by any means. And when you're just asking for transparency, it's like if you are using the program correctly, then what do you don't have to hide anything, right? And I think so those are the biggest things because we know there are good actors doing fantastic work because of this program. We know that there are so many important communities where this has been critical to care. So we want to make sure we're able to protect those pieces of it while making sure that the funding is going where it needs to. And so we have a question about the recording and slides being shared. So yes, this recording will be available on the YouTube channel, I believe, immediately following this conference. In the chat, we've shared some of the information, the links to the NCL report, some of the Tiger Lily information, but I believe we can also just share the slides separately from this conversation, right? I'm
Yeah.
assuming. Okay. And then there's just a question about if we have any information or are familiar with the Hill-Burton Act as it relates to hospitals. I cannot speak to that in particular, but.
Yeah.
Okay. So I think that one's a no. All right, not seeing any further questions here. I just want to take a moment once again to thank all of you for joining this conversation, for all the work that you're already doing. Like we've said, this is exactly what needs to be done. People sharing their stories, people sharing their voices, combining research data, patient stories. This is not a one entity, one industry, or one organization is going to be the one that makes the big difference. It's really how all of these groups and voices can come together to share those stories and ask Congress to act in ways that are actually going to be beneficial and actually expand that access to care. So thank you guys so much for the work you're doing, for sharing your stories with us today. And then thank you just for those who tuned in and continue to be interested in learning more. We're so happy to continue providing and finding opportunities to share this work and continue to educate and provide resources for people so that we can actually enact that change. But thank you so much again. And I hope everyone has a wonderful rest of your Friday. And like we said, we will be sharing this recording. So really appreciate everyone doing this work.
Thank you.